Here we are.
Yeah.
How are you?
I'm good. It's so good to talk to you and see you.
I
It's
know.
over 10 years, right?
Yes, I've just been stalking you on Instagram.
Yeah, as we all do.
Right, right. I'm not alone, right? So just so everyone knows, Andrew and I went to nursing school together. It was a second degree program at Georgetown, and we've been stalking each other ever since. So tell
And I
everyone,
stalk everybody else at Georgetown as well.
I'm gonna follow you. I'm being social. What was that movie or that show where he was a stalker? I never saw it, but you'd see all these memes from women like, man, I wish my man would stalk me like that. It's not funny, but I wish mine cared enough to follow me around. Anyway, okay, so everyone well, they know now Georgetown was a second degree program, but and that's where we met, but where did you start? Where are you from?
Yeah, so I'm born and raised New York City, from the
Okay.
Bronx specifically. Yeah. So I stayed there till I was 18, then left for college in DC.
Okay.
And then I went to Georgetown shortly after that. So
Okay. So what
yeah.
was your degree in your first degree?
Yeah, I majored in communications and music. So I thought of being a concert pianist. And then I realized quickly that that wasn't a viable career choice, and that very few people actually make it. So I needed something more stable.
What do you do? Do you put on concerts or something? You develop your own
Yeah,
pianist brand?
yeah.
Is that what it is?
It's like any kind of entertainment field where you get an agent and you try to book as many gigs as possible. And obviously the top performers make it to Carnegie Hall and Lincoln Center and all that, but it's hard. And I
Yeah.
always wanted to work in the healthcare field in the back of my mind. I just didn't know how to or where to go. So this nursing program at Georgetown kind of fell into my lap, and I'm so glad that I pursued it.
Yeah, me too. I my first degree was from Texas Tech in Spanish. I was going down the biology track and I wanted to go to medical school, and I decided I didn't want to do all of those years and years and years of schooling, and then I was going to be a teacher, a Spanish teacher. And then I'm like, I did my student teaching and I'm like, nope, not doing this. And so I went into the Marines actually. And then after that, I'd always loved biology. I'd always loved the medical field. And I had that minor in biology. And I'm like, well, why don't I just add a couple classes and, go to nursing school? And I was like, I am not starting over. So I started looking for second degree programs where I'm like, I need to earn money quick. I think that's what most
Yeah.
second degree people are like, hey,
Uh,
I'm out in the world now. I understand it takes money to live. I need to get this over with quick. So, but I got into Georgetown. I loved the program. Did you love it?
I I loved it, and the classmates, the professors, the smaller kind of professor to student ratio, and then the scholarship didn't hurt. So that all that put together, was a great experience. So,
Yeah, just so everyone knows. So you apply to Georgetown, and spoiler alert, it's expensive. But they were offering a scholarship. It was 80% scholarship at the time, but you had to promise to work for Washington Hospital Center, which is a massive hospital in DC. And honestly, I wouldn't have done the program if I didn't get the scholarship, because I just didn't have that kind of money. But you got the scholarship, and then we both went to Washington Hospital Center. So where did you start at Washington
yeah.
Hospital?
I started on a behavioral health medicine unit.
Okay.
So it was a med surg unit, but most of the patients also had some behavioral health component. So it was quite challenging being a new grad and being kind of thrust into that world. But looking back, it was a great place to start because I mean, if you could conquer that and build your skills in that kind of environment, everything else is easy peasy from there.
Right. And just so everyone knows, Washington Hospital Center is a very urban hospital, a very big hospital where you see all sorts. I mean, you're going to see the gamut. It's not like you're in the rural community where you might get ones and twos. No, it's like boom, boom, boom. Wow. Okay. So did you stay
Yeah.
there for 3 years in the same unit? Or did you bounce?
No. um, the unit has a shelf life.
Right.
I mean, some people stay there a little longer, but I stayed there for about 10 months.
Okay.
And then I went up to the obstetrics unit.
Good.
And so kind of rotated around the nursery, the special care nursery, antepartum, postpartum, and labor and delivery. And kind of going back before, starting my job at the hospital, the reason why I became a nurse was to work with the HIV population.
Okay.
And, we don't have HIV AIDS units anymore in the hospital, thankfully. But what that experience in OB provided me was there were quite a few mothers who came in to deliver and were being diagnosed simultaneously,
Really?
or had already known their diagnosis. So it really lended me that opportunity to work with that population, which is my passion. So it kind of all fell together during my time there.
Yeah, if I remember correctly, so I was down in the ER. That's where I started, and then I went up to 4G, which is an ICU, and I think I came back down. They were starting. You might know this better than I do, but it was an ER. It was like a special room it was HIV testing. I don't know if it was a pilot program. Do you recall that at all?
I don't recall that specifically in the ER, but back then there was efforts to make testing much more accessible and much more private. So it wouldn't surprise me that that was happening in the ER. Yep.
Now, correct me if I'm wrong. I think most of the nation, they just don't realize it. HIV rates, at least 10 years ago, I mean, I think they rivaled like sub-Saharan HIV rates. And so it was a pretty prominent public health issue. Is that correct?
In the DC area, it actually was more than
Oh,
many
really?
sub-Saharan African populations, right? Which was a shame because we're in our nation's capital, and
Right?
this is happening just under, the nose of our government. And, the social determinants of health and who this affects definitely plays a role in why that is happening still. But we've come a long way. And yeah, I'm thankfully things have turned better, but there's still so much work to do.
Right. So you were in the behavioral unit, and then you did your tour with mother baby, we'll say, and then you
Yeah.
started doing the
Yeah.
testing and that sort of thing. So what next?
Yeah, and then I jumped to the outpatient world. I got a job in New York City. I wanted to move back home at an outpatient clinic with New York Presbyterian, which is a large hospital system in New York. And the clinic was specifically for people living with HIV and people who wanted to come for prevention services for pre and post-exposure prophylaxis, in addition to all the STI testing and treatment. So it was kind of like my dream job. If I was going to work as a staff nurse, that's where I wanted to be. Yeah.
So what were your responsibilities there?
Yeah.
What was your role, I guess?
Yeah. So the day-to-day was, triaging. We had walk-ins, a lot of telephone triage because it was outpatient, giving vaccines, drawing blood. And then my favorite part of it was really the case management piece and providing that education. So if someone came in for HIV testing, we would not just do the test, but counsel them on all the preventative services if you do test negative. And then if you did test positive, just linking them to care immediately in our clinic if they chose to. And just really teaching patients that, a diagnosis in 2022 is way different than it was in 1982. So just giving them the right information, and removing the stigma out of all this. I find that there are so many places still that carry so much judgment and stigma when it comes to HIV and sexual health in general. It's a very uncomfortable topic for a lot of people, but just removing that barrier as much as possible really does help the patient and the providers to have more honest conversations.
Right. And I think removing I think the stigma and I prevents from getting care, which, you know, just it makes it even worse, I would say.
Yeah.
Okay, so were they receptive in your case management role? Because I'm a case manager now, and I have some patients that are receptive to that, and some it's hard to get them, you know, to come along on the ride with me. What was
Yeah.
your experience?
Yeah, definitely there were patients who were, you know, from the get-go, just tell me everything. I want to be involved. And then you have the other end of the spectrum, of course, where there's so much internalized stigma from their own communities that shame of being even a member of the LGBT community, much less than having HIV, just really paralyzes somebody from engaging in care. But just knowing that there is this safe place to come whenever you are ready, and just providing that open door eventually will lead someone in most cases to open up and engage. So that's been my experience, luckily, so far.
Yeah, I think when they learn, hey, this is a safe place, this is private, you know, and you can come here and, you know, get judgment-free care. Don't suffer in silence, sort of thing.
Right.
Okay, so how long were you at the clinic?
Yeah.
Clinic
I was there for almost 8 years.
Wow.
Yeah, that's a telltale sign of me enjoying the work. So yeah, the majority of my career was at that clinic. And the opportunity to not just do patient care, but to work on quality and to work on policy that affected thousands of our patients, and even more than that, because it's not just our patients that you know, policies affect. They affect their partners and the whole city of New York, really. So that really opened my eyes into seeing where else I can take my nursing career. So while I was there, I pursued my master's in community and public health nursing.
Okay.
And so, right when I finished that degree, I learned that this policy and quality work that I've been doing at the hospital, I can scale it up at a national level,
Okay.
which made me apply to my current role in the federal government. So I've been in this role for about 4 months. I work for the Indian Health Service,
Okay.
which is a federal agency under the Department of Health and Human Services. So we take care of over 2 million American Indians and Alaska Natives throughout the country, not only providing healthcare, but all of the other kind of social determinants and access that many of our populations still face challenges in.
It's so interesting. I don't know how you would have run into her. I interviewed a gal. She was, I think she was a case manager. I'll have to go back and look at my notes for an Indian health system in Arizona. And she said when she applied to it, she went on Indeed. She didn't really know that it was serving, you know, specifically the Indian population. It was just a health system. She's like, okay, well, I'll apply to this health system. Well, she gets into it. She's like, oh, wait, and so she learned all about how it's organized. She absolutely loved the way she loved the patient population. She loved her job. She, that was in Arizona. She eventually had to move back to, you know, the DC area, but she absolutely loved it. And it's so funny. I have another friend. What a small world. She works for Indian Health Services, but she's in their forensics department. She just started a couple of months ago because I think they're looking to, I imagine, you know, kind of like looking to increase their care for the HIV population within the Indian population. They're looking to increase patient access to forensics and, you know, if they've been assaulted and that sort of thing. So I think that's really cool.
Is she based out of Maryland by chance?
Yes.
Okay, I think I knew who she is. She sits kitty corner from me at the office.
Way.
So, yeah.
She just started November.
Yeah, that makes sense.
Okay, so you know her.
Timeline. Yeah.
She worked because when I was an ER nurse, I worked, I did part-time sexual assault nursing because in DC, if you were sexually assaulted and you wanted to pursue it, you wanted, you know, an examination and a rape kit to be collected, you would come to Washington Hospital Center and a nurse who was specially trained would come to you to collect all the evidence, lock it, you know, maintain the chain of command, lock it up, that sort of thing. Well, she was very involved in that. And I think that program, it was sexual assault nurse examiner at the time. It has transitioned to DCFNE, which is DC forensic nurse examiner. And she was in that for a long time. And then she just got, she just going up the scale. Wow, what a small world. I'm trying to
What a
get her to
small
come
world.
on. She's nervous. She's like, I'll have to ask my boss. And I'm like, it's fine.
I'll
So
talk to her when I see her next time. Yeah.
please say, I talked to Erica. You're fine.
Yeah.
So, okay, so you started this. What exactly is the role that you're doing? What's the name of it?
Yeah, so I'm the national clinical coordinator for the HIV Hep C STI program.
Okay.
So this is a brand new role. Congress allotted funding just only last year for this program. Knowing that, many American Indians and Alaska Natives are underdiagnosed with HIV and Hep C and STIs, and that the infrastructure just isn't there, more so than the private sector. And because so many of our populations live in remote areas, this program really is needed to reach those hardest to reach patients and to bring funding and resources, because although the prevalence of the HIV epidemic isn't as large as other populations, the incidence rates are comparable or even higher. And so when you have a community of, let's say, 500 people and 20 test positive, that is a huge number. Whereas if we just look at the number 20 out of a million in New York City, so it's just understanding that even in rural and remote communities, HIV and this endemic is still very much an issue.
Right. And just because the numbers aren't as big as what you're like, oh, that's just a few people. No, for this community, it's massive.
Right.
Wow.
And these communities are so tight knit, right? It's such a communal environment that adds even extra layers of privacy and stigma, as we've mentioned again, and judgment, because everyone's related to everyone, and it's hard to get care when it's your cousin that's giving you the diagnosis, or it's your sister who is triaging you in the clinic. So coming up with more creative ways to protect that patient privacy, whether it's through telemedicine or home testing that they could do themselves in the bathroom. These are all interventions that you normally don't think about in the private sector, but I'm quickly learning is something that we need to implement in this role.
Okay, so who were your contacts? Or I guess, what is the goal of your position then? Just to increase awareness? And how are you going to do that?
Yeah, so we have to go by the HHS kind of pillars of ending the epidemic. So there's 4 pillars. The first is diagnose. So just getting everyone who currently has HIV and Hep C and STIs to know their diagnosis. And we can only do that by testing, right? So just increasing those testing services, not just in clinical settings, but in non-traditional settings as well.
Okay.
And then the second part of that is to then link people to care if they do test positive. How do we get them treated quickly and retain them in care? How is that possible when the nearest clinic is a 3-hour drive? Or that the clinic that they want to go to is staffed by their family members. So using that telemedicine option, as I mentioned before. And then the third part of this is prevention. Really just accessing prevention medications for HIV. We have PrEP and PEP. These are really simple interventions that we didn't have 10, 15 years ago, that are highly effective, but underutilized. And then also just, more of that sexual education that's culturally sensitive. A lot of the messaging that we see from our government doesn't take into account all cultures and all kinds of environments. So that's something that we are definitely putting to work in right now. And then the last pillar that isn't really talked about as much is the response to outbreaks. And so when we have clusters of HIV or Hep C or STIs, how do we quickly respond to these so that it doesn't spread any further? And that's why I'm actually here in Montana right now. I've been here for a couple of weeks. We're responding to a syphilis outbreak. And more concerning is congenital syphilis, where we had quite a few stillbirths due to syphilis. And so just quickly getting on the ground to see what are the current barriers, what has been working well, and how do we kind of go from there?
Wow. So just so everyone knows, Andrew and I, we've established that we stalk one another on social media, and I see him traveling everywhere. I'm like, Andrew, where are you going? And what are you what are you doing? And he said, well, it's for my job. And I'm like, oh, this is so cool. What job are you doing? And that's what led to this. And so when you're traveling, like right now, you're specifically addressing an outbreak, but is that why you travel always, or are you like visiting all of these different reservations or Indian
Yeah.
health systems? Like, what are you doing?
Yeah, I'm hoping that my job isn't responding to outbreaks as frequently as I have been doing.
Okay.
Hopefully, we avoid outbreaks to begin with. So,
Right.
yeah, the reason why I'm here in Montana is because they just don't have enough nurses.
Okay.
It's in a very remote area. It's hard to get staffing, and we just need nurses right now to test and treat. That's really the bottom line. So that's why I'm here right now. My other travels have been more focused on training and providing technical assistance. And
Okay.
so not only providing, knowledge of HIV and PrEP and PEP, but how do we implement kind of programs and how to get that off the ground so that the clinicians who are there locally can then take it from there and build. So my nursing background definitely has helped in that piece of this, because a lot of this is nurse driven. You have nurses and nurse practitioners pretty much in every clinic running the show. They are the ones who know their patients the best. They know who is at risk and who may be at risk, and develop that rapport and get them into prevention and treatment. So it's been exciting to have that nursing connection still. Even though this job doesn't require a nursing license, it certainly has helped.
So when you go, because this is another thing, because I'd asked you, I said, well, does this require a nursing degree? And being a clinical coordinator for IHS, and you said no. And then I saw, you were saying, oh, I'm giving shots. And I'm like, that is nursing. What do you for when you go to these outbreaks? Is that different than the clinical coordinator position and you're just doing something extra?
Right. And this job isn't, defined in stone, because it's a new position and it's
Right.
fluid, and the needs are fluid as well, right? Syphilis, for instance, has been around for a while, but the rates of congenital syphilis and mortality is something new. So that's why I'm here, and that's why the job keeps changing. But when I signed on for the job, they told me the majority of the job would be helping kind of the grantees and the programs with implementation of programs and policies.
So when you go to do your education, who is the recipient of this education? Is it primary care physicians or clinics, or who is it?
Yeah, so most of our clinics are set up that are primary care based because they're so small that they don't have the resources to have like an ID specialist or any type of specialty. So primary care and the ED are really the two main access points of where our patients receive care. And so if we can meld in all of this endemic work into those two settings, we're really going to capture most of our patients that way most effectively.
And if they don't have, let's say they don't have the staff to do the follow-up, you said that you're introducing sort of this telemed option. Is there like a national telemed option for people who are HIV positive? Like, how does that work?
Yeah. So in Indian country, we have something called the ECHO program. And so if your clinician or provider isn't well versed in the HIV endemic world, you don't want to refer that patient outside where the nearest clinic who can provide that is 3 hours away, because the patient's not going to go. So then this ECHO program really serves as an opportunity where clinicians and clinicians can learn from each other and submit case reports and work things out in real time from people who are well versed. So it's really a support network for each other, because HIV in Indian country at least affects more the southern half of the country, whereas Hep C affects more the northern half. And so if you are someone in the northern half of the country, you're not seeing much HIV, then you're going to connect with somebody in the southern half who has been doing it more often, and vice versa. So it's this the synergy that's been working well thus far with that telehealth option.
Yeah. So, sorry, my cat is scratching my bed. Have, because it's a new program, and because in certain areas HIV has a high stigma, even among providers, have you found that the people that you're talking to are open to your program, and they're like, yes, we need this, or they're like, no thanks?
It's a mixed bag. Yeah.
Okay.
I think there's some people who still don't realize that there are these numbers and there are these people out there who are not diagnosed, and it is in their communities. And so just kind of starting from there and just kind of making sure everyone is aware. We have to address these diagnoses. Is a challenge sometimes. But once you get there, everyone is here for the same reason. We want to take care of our patients and keep them healthy. And so I haven't run into any roadblocks after that point, but kind of bringing that awareness is something we need to do more of.
Yeah, because I can say, I'm from small town Texas, so it's not that, well, I guess you could say, I was pretty ignorant about it in the truest sense of the world, just words didn't know, it just didn't affect our community. And so, once you make your way through the world and then you come to Georgetown, you're in DC, and you're like, no, this is a problem. And actually, here's ways to address it. And actually, this is nationwide. And it's a really important population to serve. And so you don't know what you don't know until you know. And I think that increasing awareness, at least, and if you can expose the providers multiple times, to the education over and over and over, and then one day it clicks and like, oh, okay. And then they get a patient that has these issues and needs the support, and then the light bulb goes off. And when you get buy-in, it makes your job easier, I imagine.
And we have the tools now to do this, right? We have the biomedical interventions. We know how to end this epidemic. It's just a matter of implementing it and making it available. Because compare 2022 to 1982 again, and we didn't know anything. We didn't have any tools, and so people were kind of forgiven for not doing anything or not knowing. But now that we have this information, it's our responsibility to make sure we use it.
I will say, I will say so part of the sexual assault program is you would collect the evidence. This is in DC, you would collect the evidence, but then you offer treatment. So we could swab and we could check for every STI imaginable and HIV. But oftentimes, but we would offer treatment right then and there. So, because even if you had, a patient who, let's say they were positive for HIV, they didn't get it from that encounter 2 days ago. This was the previous encounter, but it's still important for them to know. And we would offer PrEP. It's a 28-day. I don't know if it's different now. You can tell me. This was 2013, 2012, 2013. It was a 28-day program.
It's still,
Is it still the same thing?
Yeah.
And some would take it and some wouldn't. But we offered it. It was offered free of charge. Here you go. Yeah. So we were pretty proud of that. Yeah. So now how long are you in frosty Montana?
I'm here for another week. It's actually snowing outside. I'm gonna show you real quick. We had a blizzard last week, so.
Oh my goodness. Andrew, you're in the middle of nowhere.
This is probably the most rural environment I've been in thus far. Yeah.
Wow.
Yeah.
Gosh, so you're there actually treating patients with syphilis?
The ones that we know who have cases, yes. And then more importantly, we're trying to get people in to get testing who don't know their status. And the people who don't engage in care are the ones most at risk. So I've been actually going out into the community and trying to find people and just start conversations with them to let them know, testing's easy, it's quick. Come on in. We have incentives. $20 gift card to McDonald's. So yeah, the rest of my time here, I'm gonna really be out on the road and trying to get people in.
Well, I was gonna say
Yeah.
because it's almost like you have to come up with like an advertising campaign, and if you get a map, okay, the city is, these 4 blocks, or do we put up flyers here? Do we set up station here? And, how do you
Right.
get the word out?
Yeah, yeah. I often find that if you get the right person in the beginning who kind of know the other contacts,
Yeah.
and they're kind of the point person in the community, they kind of do the work for you, because it only takes 1 or 2 people to spread the word, and much more effective than me going out there who's a complete stranger, just
Mind,
going up
I
to
can
people.
imagine the stranger from New York here. I don't think so.
Those incentives do help, though.
Hey, we got to end this thing. Do what I have to do.
Exactly, exactly. If it takes a Big Mac and fries, let's do it.
Come on in. One meal isn't going to do you in.
Right.
Infection might. So please, that's
Yeah,
true.
yeah.
So what's next for you? So you go back, you're out of DC, Maryland. That's where you are stationed out of.
Yes, yes, yes. So in the immediate future, yeah, I'm going to continue to support current outbreaks, because this isn't the only community right now affected. And then I do manage 7 grants that we distribute for the HIV program. And so supporting them, we have grantees in Oklahoma, South Dakota, Albuquerque, and then all on the West Coast as well.
Okay.
And so the lifetime of the grant is for 3 years. And so I will at least be in this role until the grant cycle ends. And then perhaps continuing my education further. I think there is a need to really bring attention to HIV prevention and how policies can be adapted and changed, is something that I really want to focus on as well. So perhaps a doctorate will.
I'm sorry, I didn't mean to
Say
cut
that
you.
one more time.
I'm
Yeah,
sorry.
say that one more time.
So getting a doctorate, but would you
Yeah.
do you go to Capitol Hill? Do you run for office? What do you do? What do you think?
Oh no, I have too many skeletons in my closet.
It doesn't matter anymore, Andrew. There's all kinds of skeletons these days.
Yeah. No, I think more on the research side and just
Okay.
bringing more inclusivity of American Indians into HIV prevention research is something that is needed, and I definitely want to pursue further. With the short time that I've learned so far, it's giving me more fire to fight the fight. So.
Well, I wonder, so here's a question. So you've been in the role for 4 months. It's a brand new role, and the role will at least exist for 3 years, let's say. Do you maybe at the year mark saying, meet with, I don't know, the powers that be or whomever and say, hey, this is what we thought the role was. These are the other things that I think are important or that we've been doing or that sort of organically happened as we're finding our way through this. Can we make changes? Can we add a role? I mean, is there a process for doing that? Or do you feel like there's someone you can go to and say those things?
Yeah, I've been so lucky, being brand new to the federal government. I had no idea what I was getting myself into.
Right.
The layers of bureaucracy and how things are approved or denied,
Right.
is like 10 times more than I'm used to in the private sector. But I'm fortunate to work with an agency and a department that is very forward thinking and very innovative. And so looking at whatever ways we have to do to get the work done, is something that I've witnessed so far. And so a lot of this will depend on funding from Congress, because funds are reallocated every year.
Okay.
And so we need to ask for more money to build out these programs and positions. But I think with my role, having been out in the communities, I can speak more on what those needs are and justify the need for more resources. And so the hope is to hire more people in our division, in our program, because it's just myself and two other people in the HIV program taking care of over 2 million American Indians. And 3 people is not enough. And especially with the challenges that we encounter, I would say even more than other populations.
Right. I love this idea of being the boots on the ground, because oftentimes, I was a Marine back in the day, and it's the same thing. You have higher ups who, let's give everyone the benefit of the doubt. They want to do good. They think that this is the way to go, 1, 2, 3. But, they're in the command tent, they're on Capitol Hill. They don't know. They just know it's being reported back to them. And then there's people like you who know, I am here on this snowy street in Montana. I'm telling you, this isn't working. This is, no, this is what we need. And, you can, I think it's just so much, there's so much power behind that. No, I visited here. And it's, this is what this community needs. So I think that's so awesome what you're doing.
Yeah. Yeah. It's awesome. It's unexpected. And I'm so glad it happened. And this is what a nurse can do, right? This is the whole kind of theme of your podcast. Who knew, right?
Yes. And I have to say, maybe I'm sure you're smarter than I am. That's a given. But, you go into this, or I went into this, and it can be, you don't have to know everything going into it. You just be like, you know what? I like to help people. I've always liked science. I'll be a nurse, and then I'll go to the hospital and work, which is wonderful. It's great. Some people stay there forever. Some don't. It's fine. And then this entire world of possibilities open for you. And nurses really can change the world. They know things. Sometimes it's hard to really qualify it with words and describe, but they can just make so much impact in so many areas. And so, when you're like, hey, I'm actually nursing and this is my position, I'm like, Andrew, come on and tell everyone. This is such important work. One, it's important work that people need to know about. And two, as a nurse, you can do this as a nurse. And if this is a patient population, either HIV or the Indian population, or both, that interests you, there's a place for you, and you can absolutely pursue it. So someone in their community wanted to they feel like they would love to serve the HIV population. Do you have any tips for them? Like, where could they go to find out more and get more involved?
Yeah, I think if you want to work directly with the population, the outpatient side would be probably the best place because, like I said, the inpatient units, we don't separate people with HIV anymore. It's all integrated. And so if you live in a city or an environment where there is higher numbers of HIV, you might run into more of that in the inpatient side. But really the clinics will be sexual health clinics, infectious disease clinics is where you will find kind of that day-to-day interaction with the population. Department of Health has plenty of positions usually who dive into this population as well. So
okay, I would think so, especially because I'm thinking down here. It might be San Diego, but even more urban is LA, and that's just a couple of hours north. So I think people in rural communities might be hard pressed to find a clinic. But, if you felt that passionately about it, you could start with your regular clinics and say, hey, do you have this? And then go bigger and say, hey, I want to start something here. You never know.
Right. And even if you start, in an inpatient environment, I've learned now that any experience in nursing is cumulative. And so what I learned in behavioral health and what I learned in obstetrics has totally helped me in this current role, because I see people with mental health issues. I see people who are pregnant. And so every experience that you have, even if that's not the job you want, 5 years from now, is going to help you, because that experience does never leave you. So just realizing that has really kind of helped me as well, building my career.
Yeah, I completely agree. Being a nurse is an experience that really just isn't like any other, and all the jobs you can do, and the next job you get all of that knowledge comes with you. I totally agree.
Yeah.
Well, Andrew, I mean, this PhD, have you even looked into it?
Slowly. Let me get my feet wet with this job a little bit further. But yeah, I think Dr. Yu will be sometime in the next 4 or 5 years.
Dr. Yu, Dr. Yu. I love that. Thank you so much for coming on. I really appreciate it.
It was so great to share this and to speak with you and catch up with you. Let's do this again sometime.
I know. You look the same, you jerk. 10 years later.
You look better, I think.
Gosh. Oh, gosh. My favorite interview.